Good morning, good afternoon, good evening to you all. Welcome to the second day of the online advanced course on Biomedical Imaging 2024. Today, we will have a panel of experts to talk about radiology and mammography. I would like to remind you that you can send your questions via the Q&A chat box or express your intention to ask questions orally by activating the raise the hand button. Our questions will be answered at the end of each talk. Now, without further ado, I give the floor to our host, Professor Francisco Caramello, from the Faculty of Medicine of the University of Coimbra.
Hello all, thank you for attending this session. It is my pleasure to present Professor Nuno Ferreira. Today, Professor Nuno Ferreira will be given a talk in radiology, and I will also participate in the talk, and I'm going to talk about mammography. Professor Nuno is an assistant professor at the Faculty of Medicine, and where he teaches several matters, notably biophysics, biostatistics, and also image processing, nuclear medicine physics, and it is my pleasure to present Professor Nuno. Myself, I'm going to present myself. I'm also an assistant professor at the Faculty of Medicine, and I'm also teach biophysics and biostatistics, and also some matters in artificial intelligence. So no further ado, I give the virtual stage to Professor Nuno, and I'm going to share my screen because I'm sharing the screen, but the talk is given by Professor Nuno, at least in the first half, and then the second half I'm going to speak the remaining presentation.
Oh, okay.
Nuno, if you want.
Muted. Okay, so thank you for inviting me for this talk. It is a pleasure. So maybe we can advance to the next slide. So essentially, I will talk about something about the radiology, about what are some applications, the production of X-rays for medical imaging in radiology, the interaction of those X-rays with matter, so how the image more or less is formed and how it is detected. So all this has to do with the way the X-rays interact with matter. And then for the mammography part, as has been said, Professor Francisco Caramello will continue. Maybe next slide. Okay, so this is just a slide that helps us locate the radiology imaging in the middle of all the other techniques. So we see there that essentially what is most differentiating from other techniques is that an external source is used, and let me just try to draw maybe. So an external source is used, and that source will emit X-rays that will go through the body, so they will be transmitted to the other side of the body. Part of them will interact in the body, so the beam of X-rays will be attenuated, and we will have on the other side of the body some way of registering the imaging. So it can be radiographic film, or it could be a detector, a solid state detector, for instance, that would register the signal, which essentially is the detection of X-ray photons, the ones that were not absorbed by the body. Actually, there is a very simple way of showing this. We basically have two types of imaging. One which is projection imaging, and it's very easy to mimic it, or more or less to do an analog of that using. Oh, apparently this is blurring, so it's more complicated. My background is blurring, although I did not select that. Yes, okay. But anyway, the idea is if I have, for instance, my cell phone with light on, and if I have the bottle, well, the bottle is blurred because this was not expected, but you can probably see that on the wall beside me, as I move the light source around the bottle, on the wall there is a projection of that bottle that is being formed. And that projection essentially is showing what regions of the beam were more affected by the object. And so how was the attenuation of the beam of X-ray? So there are points that are going to have more absorption or that will, or if you want, points on the wall that will receive more or less light from the cell phone, because more or less attenuation will appear in different parts of the bottle. So we can see the interior. So if we just take one photograph of the wall, that would be essentially one radiography. And if we move around, all around the object, taking many of those photographs, we would be doing CT, so tomography, because with many projections taken, several hundred projections taken, we would be able to reconstruct those the information in those projections, and those form a volume, a reconstructed volume that can be sliced any way we want. And so we can see the slices of the body. So tomography, that's what it's mean. Tomo means cut or slice, okay, and graphic means image, for instance. So maybe we can go to the next one. So of course, this has lots of applications. So we can do just with projection imaging. So by taking a single projection, we can view the interior of objects. And of course, this has had many applications in biology, essentially in medicine. Those are essentially some of the areas where it has been most successfully used, such as dental radiography, very commonly, or just radiography to see the interior of bones, broken bones, etc., and of course mammography also. So maybe we can go to the next one. There is a huge range of medical imaging systems that have been developed based on X-rays for radiography. So we see here some examples related to fluoroscopy, where we can see in real time the different materials and how they absorb the X-rays and form images. So for instance, where we have a contrast media that will be, for instance, more attenuating than the other tissues around, and so can be used to better have a view of the gastrointestinal tract or of the vessels with angiography, or of course of the urinary system and other applications. So in fluoroscopy, what we have essentially is we have here the X-ray source that will emit X-rays. So these X-rays will be partially attenuated in the body and will will be incident here on an image intensifier that basically will do the transduction of the photons, of the X-ray photons that were able to pass the body. It will do the transduction of this into electrons that will be then accelerated by fields, by electric fields, and they will essentially be focused, and then they will interact here. Well, once again they will form photons that can then produce an image of the body. So essentially, there is more or less this sort of complicated way of generating the images, but basically we have to convert from X-rays, which are invisible, into electrons, and then into visible X-rays. Okay. So here we can then convert that into film or into a movie, and see this with a CCD camera, for instance. Okay, next slide. Oh, now I have to erase this. Okay, so here we see what is possible. So some examples of CT, which can be used for cardiac imaging, which can be dynamic, as you can see in the lower left corner. This is a more common way of looking, for instance, at CT images in the brain. We can see those slices of the brain, which can, in this case, they would be the transactional slices, but we can also slice in many other ways the same volume of data. And we can view in this way with a 3D rendering that will show in 3D the different parts of the body. So, of course, the X-rays, they are essentially photons, which sometimes, well, very high in energetic photons, although what defines an X-ray photon is not exactly its energy. So it's possible to have an X-ray photon with the same energy as a gamma ray photon, for instance. What distinguishes the X-rays is the origin of them. So if they are related with electrons, with processes where electrons intervene, and they have a certain range of energies, then it corresponds to X-rays. But but we can have the same energy for photons which are emitted from nuclear processes, and in that case we call them gamma rays. Anyway, the photon energy usually is in this range of some kilo electron volts, and well, maybe I should explain what an electron volt is. So essentially it's the kinetic energy that is gained by an electron when it goes from a differential potential 0 volts to 1 volt. So an electron will be accelerated and it will gain an electron kinetic energy of 1 electron volt if it was accelerated by 1 volt of differential potential, electric potential. So this also has a correspondence. So there is a correspondence between the energy and the wavelength, as we know. So usually higher energies corresponds to shorter wavelengths. Maybe next slide. Okay, so what happens in a typical X-ray system, which is doing transmission imaging, essentially is we have then the X-ray tube, and this will produce the X-rays that will exit from the exit tube, and they will interact in the body. Some of them might interact by some ways that we are going to talk next, the photoelectric effect, Compton effect, and so eventually they may change direction, and for that we have here an anti-scatter grid which will try to filter out some of these photons that have changed direction, and so they will reduce noise in the image and they will reduce the contrast in the image. But then on the other side we have this detector which will register the information in an electronic medium that can be then analyzed in the computer, for instance. Okay, next slide. So the X-rays were discovered, as it is very well known, by Wilhelm Röntgen more than a century ago. And one of the first images, or the first image in fact that is known, is this in the lower right corner of the hand of the Röntgen's wife, and it was very it's a very well-known image, and it represents more or less the immediate application to biomedical imaging and to medicine of the X-rays. It was almost immediately recognized that it could be used for medical imaging. So we can continue. Okay, so how does the X-rays, how are they produced in an X-ray tube? Essentially, there is this circuit here where a high current of electrons will pass, and it will pass through by this filament. It's more or less like one of those light bulbs that used to have a filament. Not like the LED that we have today, but one of those light bulbs, old light bulbs that have a filament that will heat when a current, an electric current passes through it. And if it hits to a certain point, then electrons will be formed by thermoionic effects. And if there is a large differential potential, electric potential between the cathode and the anode, which is on the other side, which is here, then the electrons will be accelerated by several kiloelectron volts, or even more than 100 kiloelectron volts. And when they reach the anode, they will collide, and in that process, there will be the production of X-rays by essentially two processes. One will be the Bremsstrahlung radiation, which means, well, it's a German word that means essentially breaking, well, radiation due to the breaking, well, to the fact that the electrons have to reduce their velocity quite drastically, so they have to, they collided, and so in that process, a continuum spectrum of energy is produced, and part of it is X-rays. And then another process is the fact that when the electrons collide with the anode, some of them will, okay, so this is another view. When they collide with the anode, the atoms in the anode will be ionized, and when they return to the original state, they will emit X-rays. This is just a brief explanation of what happens. In fact, the electrons, they will heat and ionize an atom in a way that the electrons that are closest to the nucleus, they will leave the atom, and then when the atom returns to its original state, it's then at that point that the X-rays will be emitted. And those X-rays will produce a characteristic spectrum. So Bremsstrahlung will produce this continuous spectrum, which we can see here for different electric potentials between the anode and the cathode. And that difference potential will determine the maximum energy of the X-rays. Okay? And here we can see that the characteristics X-rays, which are also produced in this X-ray tube, they are going to have always the same energy, because they are characteristic of the material in the anode, the atoms that are in the anode. Okay, we can. Oh, by the way, maybe we can just go behind here to the slide again, just to show that. Well, that no, the other one. Okay, because no, before that one. Okay, this one. Because this is showing that when the electrons hit the anode, this region here will heat a lot, Sometimes we have rotating anodes so that it will not be always the same region being heated, but essentially more or less 99% of the energy that was used to accelerate the electrons, it will be lost as heat, and only 1% more or less will be used to produce the X-rays. So essentially this will heat a lot, and so there are ways of trying to reduce this heat. And one thing that I did not mention is that it's very important to have vacuum here, or near vacuum, so that the electrons will not ionize these atoms here. So they will only hit the anode, and only then in the anode they will transmit their kinetic energy. Okay. So this can maybe, now we can pass to the next slide, where we can see that if we, a very simple way of seeing the effect of electrons being accelerated is using this Leonard tube, where there is essentially an anode and a cathode, which are being which are being used to create an electric field, a large electric potential difference. So the electrons will be accelerated, and in that process, if there is a gas in this bottle, in this adapted bottle, then those electrons will hit those atoms and light will be generated. So and some of the light can also correspond to X-rays. In effect, for instance, that green zone means the corresponds to the cathode, and on the bottom of the bottle, there is a metal piece that prevents electrons from passing that, and in fact, electrons will collide here, and there they will produce X-rays, which we can hear them if we use a Geiger detector. So essentially, it is detecting X-rays. Okay, so I think I will now continue to describe the interaction of radiation with matter. So essentially, when these X-rays are being emitted, they will be there will be some effects on the matter. They will interact in matter in some ways. One of the ways, well, maybe we can pass to the other slide where this will be described. So one of the ways is by coherent scattering, where the X-ray photon will hit an electron in the atom, and essentially it will change direction, but there's no loss of energy there. Here now we are seeing the Compton effect, and here we are looking at the photoelectric effect. So maybe we can maybe see this again. So the Compton effect, essentially a photon collides with the atom, the electron leaves the atom, and the photon changes direction and loses some energy. That is something that did not occur in the previous effect, which was the coherent effect. Now we are looking at the photoelectric effect, where a photon will hit one electron in the atom, and it will essentially ionize the atom. So the electron will leave the atom. We will lose one electron in this atom, and so then the atom has to return to its original state. But we have lost the electron in that process. The photon in that process. So the photon has been absorbed. This is probably the main effect that we see when we have X-rays passing through the body, and also the Compton effect. Those two are the main effects that we will the photons will experience, as can be seen in this region. So this is more or less the range of energies that are typically used for radiology, and we can see that essentially this is what is due to the photoelectric effect, and this is what's due to the Compton scattering. So sorry, and these two effects essentially contribute to the loss of part of the beam that that is traversing the body. So next slide, maybe. Okay, so now this is where maybe Francisco will continue.
Yeah, we can change gears here.
Yes, so I did not mention that those three effects, they are basically what is behind the fact that the beam of X-rays will lose lots of a photon when it is detected on the other side. So, but it's always also the way that the beam that we use to detect those X-rays. So the absorption of X-rays and the detection of X-rays is directly depending on this photoelectric effect, this Compton effect, and to a lesser degree on other effects, physical effects. Okay, so thank you. I now leave it to you, Francisco.
Thank you, Nuno. Thank you again for your presentation. I'm taking from here. So I'm going to talk a little bit about mammography. Mammography is one of the applications of X-rays, but mammography, it depends. It has to have some kind of adaptations because of the problem. One of the problems is that the tissue that we are imaging is different from the skeleton, for example, and the attenuation coefficients are very close to each other. So when we compare the breast tumor, for example, with the adipose tissue in the breast, we see that the coefficients, the attenuation coefficients are close together. But we also know that these attenuation coefficients, they are depending on the energy. So in order to make the difference larger, we should lower the energy, and so if you want to lower the energy, we have to change the material in the anode. And the other issue that we have is that the lesions that we intend to image, they are typically very small. So we need improved spatial resolution, and so the X-rays for mammography must have also this into account, and that's to make some changes in order to improve the spatial resolution. Okay, so the first issue that I mentioned is the energy. So in order to lower the energy and to have low energies in the X-rays, we change the anode. Instead of using tungsten, that is the anode, the usual anode in X-rays, we use molybdenum or rhodium for the anode. And you can see here that this spectrum is for molybdenum, and you can see that the characteristic X-rays is more or less on the 70 kiloelectron volts. And we try to use this characteristics X-rays for doing the image, but we also see that we have a large continuous tail, and we want to filter out this large continuous tail. And in order to filter out this tail, we can use different filters, and the filters also have different materials, and the usual combinations of materials will give different energies for the X-rays. So one of the forms is just using a molybdenum filter. Also, we use an anode filter and a molybdenum filter, and we take advantages of the K cross section, because when the energy is similar to the energy of the K layer in the atom, the electron is ejected, and we have photoelectric effect, and that photons, they are also filter out. So we can see that if you use a molybdenum filter with also a molybdenum anode, we can see that the spectrum becomes much lower also, but the tail is almost filtered out, and we can see that we have almost a monoenergetic beam. It's not a monoenergetic beam, but it's a reasonable approximation for a monoenergetic beam. And we want to, it would be ideal to have monoenergetic beams for X-rays. And the other combinations could be molybdenum and target an anode of molybdenum and then a filter of rhodium, or an anode of rhodium and a filter of rhodium. If we combine molybdenum with rhodium, we get medium energy, and also with rhodium and rhodium, we can say that we have high energy. Of course, when we say that we have low or medium or high energy, we are saying that low energy is around 20 keVs, and the high energy is more close to 70 or 100 keVs. It's not that different, but the difference is important for trying to discriminate the attenuation coefficients in the breast. And the other point that I talked earlier is the spatial resolution. So in order to improve the spatial resolution, we try to minimize or to make smaller the focal area. But if we make smaller the focal area, the length that are being heated is shorter. So we have a more concentrated heat, and if we just leave it like that, the material of the anode could melt it, and we don't want that. So in order to prevent this effect, we lower the electron density by lowering the current, the electric current in the filament. So if we have a flux of electrons that is lower, then we will also have a flux of X-rays that is low. So in order to maintain the signal to noise ratio, we have to increase the exposure time, and that's why that mammography has some the exposure time is higher than the conventional X-rays imaging. And another aspect that we have to take into account is the Hill effect. The Hill effect is associated with the cross-section of the effect, that the cross-section, the probability of getting X-rays is not equal when we consider the angle. And we see that the intensity is higher, the probability is higher in one of the sides, in the side that is close to the cathode, and it's smaller in the other side. So when we place the tube and we make the mammography, the breast, or the part that is more close to the breast receives a more intense beam, and the part that is closer to the nipple receives a beam that is less intense. So the image, the signal to noise ratio in the image is higher in the close to the breast, close to the chest, and is lower close to the nipple. And also this is something that should be taken into account when we are doing the images. And another effect that have some pros and some cons is the compression. In order to maintain still the breast, usually it's used a compressor, and the compressor is made of a material that attenuates the X-rays, but the materials is selected in order to minimize the attenuation of the X-rays. And but the compression also it will make thinner the breast, which improves spatial resolution, and but as the con that it causes discomfort. So the pros is that we get less. The pros of compression is that we get less scatter. We can lower those because we don't need so much intensity, and also we don't have motion artifacts. We could have motion artifacts due to the fact that the exposure time is increased, but since the compression makes the breast to become still, we don't have motion artifacts. We also get an higher spatial resolution, and I will explain this later. And also we can also get some less geometric amplification due to the compression of the breast. And of course, because the breast becomes thinner, we will get less overlap of structures because we are projecting. We have a planar image, and we are projecting the structures of, within the breast. But a very big con is the discomfort, and the discomfort is a nice way to say pain, because women that they are the breasts are compressed and they feel pain, and this could be very could affect usually the exam. Okay, what is geometric amplification? Geometric amplification is due to the fact that the distance between the source and the object could be larger or could be smaller, but when it's smaller, when the object is closer to the source, or for example, on the other end is far away from the detector, we get a magnification and amplification of the structure. And with the compression, we see that the compression makes the breast that become more close to the detector, so it decreases the amplification. That's, we can say that that's not a good thing, but because small structures would become less visible, but we can maintain if we want, we can maintain the geometric amplification by introducing some air between the detector and the breast. And another form of doing tomography, which is almost the current mode of doing tomography, and that has several advantages, is known as tomosynthesis. And in tomosynthesis, the source moves around the breast in an arc. So several images are taken, and then the different images are used to do a reconstruction, and we can obtain different slices from the breast. And the tomosynthesis is with the tomosynthesis we can discriminate structures that otherwise they would be projected and overlapped in a single image. So we can say that one of the disadvantage could be the exposure time and the dose for the patient. But again, we can resolve some problems, and we gain some contrast and sensitivity in the image. Okay, just wrapping my presentation, we can do a comparison between mammography and radiology. You can see that mammography uses low energy between 25 to 35 kVp, whereas radiology we use high energy. It's not that high, but it's higher than mammography, and uses between 50 and 125 kVp. The anode is also different. In mammography, typically is molybdenum, and in radiology is tungsten. And this is the use of different anodes is the reason that we get different energies. And also in mammography, we tend to use lower electric current in the filament, and when compared to the radiology, and this is due to the heat that is produced in a small area in the anode. And as we use lower electric current, the exposure times tend to be higher in the mammography. So we have typically exams that take 1 second, but when we compare that to radiology, they are very short, like typically in order of 50 milliseconds. And in mammography, as I said before, we have a small focal area in order to increase the spatial resolution, while in radiology the focal area is larger. And also the window between the X-rays and after the production of the X-rays in the tube, we have a window of beryllium, and while in radiology we can have a window of Pyrex. We use beryllium because beryllium has a smaller atomic number, and as we are using lower energy, we need to use a window with a smaller atomic number. Otherwise, the X-rays would be attenuated and did not reach to the body. And also another different aspect is the kerma. In mammography, the kerma is in air is high, whereas in radiology is low. The kerma is about 100 milligrays in radiology, in mammography, while in radiology is 5 milligrays. So the dose to the patient is different in mammography and radiology, being larger in mammography. Okay, and this is the end of my presentation. Thank you all. I think I managed to fulfill the time. I don't know if there is any question. I don't see any question in the chat. I don't know if there is any question in the raise your hand. No. Okay. Okay. So we can now move on to the next presentation, and the next presentation will be given by Dr. Ana Paula Borges, who is a specialist in radiology, and Dr. Ana Paula Borges is going to talk about conventional radiology and the clinical applications of conventional radiology. Welcome, Dr. Ana Paula.
Hi, good afternoon. I will share my screen.
Yes, please. the floor is yours, the virtual floor.
Okay. Can you see everything? Okay.
Yes.
All right, now let's begin. Hi, everyone. I was already introduced. I'm Ana Paula Borges. I am a radiologist in Coimbra Hospital and University Center and a PhD student in University of Coimbra. This year, I was once again invited to talk to you about the clinical applications of conventional radiology. So I will start my presentation by listing some pros and cons of the technique, talk about some basic notions, and then I divided the presentation in chest radiography, abdominal radiography, fluoroscopy studies, and musculoskeletal radiography. And finally, I will mention the role of artificial intelligence in conventional radiology. Regarding the pros and cons, the main advantages of conventional radiography are that it is cheap, available, fast to perform, and it can be mobilized, for instance, to perform chest X-rays in the patient's rooms. The downsides are that it is a bidimensional technique with low soft tissue contrast resolution and, of course, the use of radiation. The great problem with radiation is the risk of inducing cancer. And although radiography has a much lower dose compared to an abdominal CT, for example, we must remember that all of this is cumulative, and we must always have in mind this principle of security that aims to minimize the exposure to radiation, not only in terms of protections when the exams are being performed, but also by avoiding to request radiological exams without a clear justification. A great step in the history of radiology was the arrival of the digital acquisition. For many years, radiographs were acquired, processed, visualized, and stored in films, but in comparison to what we have nowadays, the image quality was inferior, and if the initial exposure was not adequate, the only solution was to repeat the exam. Another problem was the need for physical space to store the films, which would be very complicated with the amount of exams that are currently done. In a digital system, we have the image acquisition to a digital detector. The analog signal is converted into digital, which is processed in a computer and then stored. After that, at any moment, it can be converted back again to be visualized as an image. It is a much faster process. The image gets better quality. It allows post-processing, for instance, to adjust the contrast, and we no longer have the limitation of physical space, only that of digital memory space, which is easily solvable with money. And the great limitation of the digital technique is actually the price, and that's why some hospitals in the world still don't have access to it. Now, an important notion that we must know is that in a radiograph, we are limited to the differentiation of 5 basic densities. And that has to do with the degree of X-ray attenuation by the structures, which will depend on their density, thickness, and atomic number. Of these 5 densities, 4 are natural from the body. We have the air density in the lungs and in the bowel, which is almost black or radiolucent, and that's because the air does not absorb X-rays. The bone density is the densest because the bone absorbs many X-rays. And basically, when the X-rays are absorbed, they won't contribute to the blackness of the image. In the middle, we have the fat density and the soft tissue density in the organs or in the muscles, for example, which is similar to the fluid density. The 5th density is the metallic, which is the densest of all, as we can see in this belly piercing, which is obviously not a natural density from the body. Now, the final notion that I would like you to know is the notion of the silhouette sign, extremely important in radiology. Basically, this sign is present when 2 structures with the same radiological density are opposed to each other, and we no longer see the interface between them. It is highly useful for us in the way that it helps us to localize disease, for example, a pneumonia that opacifies the normal lucent lung. In this example, we know that it is localized anteriorly because we cannot see the right heart border, which is an anterior structure. If we did see the heart border in a case like this, we would know that it is localized in the posterior lung. Okay, now let's begin with chest radiography. Starting with the how. First, we need to understand the notion of a radiographic projection, which is basically the direction of the X-ray beam in relation to the patient's position. We have several ways of doing this, depending on what we want to evaluate better and whether the patient can move to a certain position or not. By far, the most commonly used is the posterior anterior, in which the patient is standing at 180 centimeters from the X-ray source, facing the detector, because the farther away from the source and the closest to the detector, the better the image will be. The anterior posterior is the other way around when the patient cannot stand up, and the lateral is usually with the patient's left side against the detector. We can also have lateral decubitus, expiration, lordotic, which I will explain in a moment, and also obliques or directed to the ribs or sternum. The major problem with an AP projection is that the anterior structures, namely the heart, will be amplified as they are farther from the detector, and an amplified structure loses definition. Another problem is that the scapula appear projected over the lungs, therefore hiding some of it. Also, the patients who usually need this projection are the ones who cannot stand up to do the usual PA, and that often means that they are debilitated and consequently their degree of inspiration can be low, which further impairs the radiograph evaluation. Now, why should we do a lateral projection? Mainly because it allows us to localize pathology because we add a second dimension. And it also shows the retrosternal and retrocardiac spaces and the posterior costophrenic recesses where a small amount of fluid can accumulate first and not be visible in the frontal projections. Despite all these clear advantages, we don't do this projection by routine because it increases the radiation dose. The lateral decubitus projection is mainly used as a problem solving, for example, to see if an effusion is free and spreads as occurs in this example, or if it is loculated, in which case it won't spread. It also helps to detect small amounts of air or fluid. To see air, the patient lies to the opposite side and the air will rise. And to detect fluid, the patient lies to the same side and the fluid will accumulate in the bottom. It may also be helpful to have the radiograph taken during expiration. And why would that be? Well, normally, when we exhale the air out of the lungs, they will become less lucent, more dense, as you can see in this example compared to the radiograph in inspiration. And when that doesn't happen, it means that the airway is obstructed, which could be from several causes, for example, an inhaled foreign body. Also, the increase in the lung density may facilitate the identification of small amounts of free air in the pleural space because the difference in the density of the lung and the air will increase with expiration. The lordotic view is taken with a tilted X-ray beam pointing up to see the lung apices without the superposed clavicles. It was very used for patients with tuberculosis, which has a predilection for this part of the lung, but nowadays it is very rarely done. Interestingly enough, when we do see a projection like this, it is usually by accident due to incorrect position of the patient. Now, first things first, it is crucial to ensure that the technique is correct so that we avoid errors in the interpretation of the radiograph. In a frontal chest X-ray, there are 5 technical factors to be assessed. First, the exposure, that is the degree of X-ray penetration along the body, which is the opposite of X-ray attenuation. If we have a radiograph with too much exposure, that means that a lot of radiation passed through the body and wasn't attenuated, and therefore the radiograph becomes very dark and we may not see vessels or nodules, or we may falsely diagnose emphysema. As a way of simplification, we could think as if the X-rays painted the radiograph black. If, on the other hand, we have low exposure, the radiograph becomes very white because there was significant X-ray attenuation and they did not pass through the body to reach the radiograph. If we have a white image, it could hide anomalies such as a pneumonia. So how will we define if the exposure is adequate or not? The criteria is that we should be able to see the spine through the heart shadow, but not too well. In this example of low exposure, we do not see the spine through the heart border nor the left hemidiaphragm. Another important factor to consider is the inspiration. To evaluate if it is adequate or not, we should see at least 8 to 9 posterior ribs above the diaphragm, which are the ones that arise from the vertebra. Ideally, we should see 10, but in hospitalized patients, it is not always possible, so we accept a little bit less. Instead, we could use the criteria of seeing 6 anterior ribs, although those are harder to identify. The problem with the weak inspiration is that the vascular markings become agglomerated, especially in the lung bases, and that could be mistaken for a congestive condition or even a pneumonia. And besides, the heart looks larger than it actually is. We also have to establish if the radiograph is well-centered without body rotation, and we determine that by looking at the medial edges of the clavicles, which should be equidistant from the spinous process. If such distance is different, then the patient will be rotated to the side in which the clavicle is farther away from the spinous process. For example, in this case, the patient is rotated to the right side, so the right clavicle will be farther from the spinous process. The problem with rotation is that the anatomical contours will be deviated from their normal position, and the side that is farther away from the detector will become amplified. Regarding magnification, we already said that the farther away from the detector and the closest to the X-ray source a structure is, the more magnified it will appear, and a magnified image becomes less nitid. That's why the heart appears to be enlarged in an AP view. Both of these radiographs are from the same patient in PA and AP projection, and the heart clearly looks enlarged in the second image. Knowing why that is avoids false interpretations. And finally, the last factor to take into account is the angulation of the X-ray beam. Normally, it should be horizontal, parallel to the floor and perpendicular to the patient's chest. When it is tilted up or the patient is leaning back, we get a lordotic view that is not intentional. The clavicles appear at the same level or above the first ribs and ratify. And a problem with this error, so to say, is that the heart's morphology will become distorted and we no longer see the contour of the left diaphragm. Now, what about the what? What is normal? I won't be exhaustive in describing anatomy, don't worry, but basically we should evaluate the airway, the trachea and bronchi filled with air, the pulmonary hilum where the bronchi and vessels enter the lung. These white lines throughout the lung correspond to vessels and are normally larger and better seen in the lower lungs that are more vascularized. In the mediastinum, we have several borders from the heart and large vessels. We should also evaluate the angles that the diaphragm forms with the heart and the lateral ribs, and we must never forget all the thoracic bone structures included in the exam, as well as the soft tissues. In the lateral view, we evaluate the spaces posterior to the sternum and to the heart, which normally should be filled with air-filled lung. We also see the vertebral column, and an important sign to know here is that the density should decrease from upper to lower, and when that doesn't happen, it means that some pathological process is present, increasing the density inferiorly. We evaluate the posterior costophrenic recesses, which is the most inferior part of the lung and therefore is where pleural fluid accumulates first. We can also appreciate the right and left diaphragm. Now, moving on to the when, in terms of indications, this is an example of recommendations provided by the American College of Radiology. They recommend that it should be ordered in patients with signs and symptoms related to respiratory, cardiovascular, upper gastrointestinal, and thoracic musculoskeletal systems. It is a good exam for initial screening of these of pathologies in these systems, giving the advantages that we already discussed. Although some anomalies may still require further clarification with other exams, and on the other hand, its sensitivity is very low for some pathologies, and in such cases, it may be necessary to perform other exams such as a CT, even if the radiograph is normal. They mentioned that it may be useful for staging neoplasms, that is detecting lung metastasis, but it shouldn't replace CT for that indication, given the limitation of radiographs in detecting small nodules. It can be used for thoracic disease follow-up, but in children, it shouldn't be done only to ensure the resolution of pneumonia, nor in non-complicated pneumonia. In the next slides, I will show some examples of pathology that could be encountered in radiographs requested for these reasons. In patients with respiratory symptoms, dyspnea or cough, for example, we could find airspace disease in the lungs, which can be manifested by hazy opacities or consolidations, as the alveoli are being filled with something other than air. These could be signs of pneumonia, edema, hemorrhage, or even adenocarcinoma in the more chronic presentations. Another possible finding is these linear reticular opacities in cases of interstitial pneumonia, edema, or lung fibrosis, as is the case in this example. We could also find lung nodules, for example, in lung cancer, lung metastases, silicosis, miliary tuberculosis, or abscesses. And we also have diseases that originate both reticular and nodular patterns, for example, sarcoidosis. Other pathologies cause reduced density in the lungs, for example, emphysema by destruction of the alveoli, in which the lung gets hyperinflated, and we will see signs of that. Besides the reduced density in the lungs, the diaphragm will be flattened, and the retrosternal cure space will become enlarged. And we may also find bullae or cysts. In the airway, we may see bronchiectasis, which are irreversible bronchial dilatations, usually caused by chronic infections, and we will see these sinus ring opacities when the bronchus and the artery are seen in cross-section, or tram track opacities when those are seen in profile. Another thing we could detect are cutoffs in the airway column, for example, in the presence of an endobronchial tumor or an aspirated foreign body. And there are also mucus plugs in the airways that appear dense, as you can see in this example. The symptoms may also relate to pleural pathology. The pleura is composed by two very thin layers, one covering the lung and the other covering the thoracic wall. And between them, there is a small amount of normal fluid that facilitates the friction between the lung and the wall, despite many other functions, of course. Normally, we don't see the pleura in a radiograph unless it is thickened, for example, due to cicatrization after some insult. In asbestos exposure, there can be pleural plaques, as you can see in this example of several calcified plaques. And we can also have primary pleural cancer, mesothelioma, or pleural metastasis. Fluid can accumulate in the pleural space, which can be secondary to lots of pathologies, heart failure or pneumonia, for example. And in radiographs, this fluid will initially blunt the costophrenic angles, as you can see here. And by physics, the fluid will rise more in the margins and originate this meniscal sign with a superior concavity. And when it is very large, it can opacify the whole hemithorax. Air can also accumulate in the pleural space, either spontaneously, usually due to rupture of small peripheral air bullae, or instead after trauma with rib fractures that rupture the pleura. And in fibrosis, it can also happen because there are many air spaces. In the radiograph, we will see a line separating the lung from the air in the pleural space, which corresponds to the visceral pleura covering the lung. When the patient is lying down, the air will rise and accumulate anteriorly, so the costophrenic sulcus will appear in a lower position. In some situations, we can have both air and fluid in the pleural space, usually after trauma or pleural interventions. In the hyla, we will look for enlarged lymph nodes, which will give a lobulated contour, as you can see here in a case of hilar adenopathies due to sarcoidosis. We may also find nodules or vascular engorgement in these regions. Regarding the cardiovascular system, in radiographs, we may evaluate the cardiothoracic ratio, which is the ratio between the largest diameter of the heart and the largest diameter of the thoracic cage. And normally, in deep inspiration, it should be inferior to 50%. When this ratio increases, it may indicate cardiomegaly, but not always. A pericardial effusion with fluid around the heart will give the exact same image because, as we said, we cannot distinguish fluid from soft tissue. There are other causes, as the AP projection that magnifies the heart, as we previously saw. We can also evaluate the aortic and pulmonary artery contours. Aortic ectasia is very common with advanced age, but the pulmonary artery dilatation may indicate pulmonary hypertension, which has a poor prognosis and should be detected as soon as possible. In this patient, in the left, we have pulmonary artery dilatation, and on the right, enlargement and calcification of the aortic arch. As for upper gastrointestinal complaints, we could detect hernias, for example, with abdominal contents inside the thorax, which could be stomach, bowel, or other. In chest X-rays, we may also detect diseases in the bones and soft tissues, for example, bone fractures and tumors. Here we have several non-recent rib fractures with some consolidation. And we may also have soft tissue masses or subcutaneous emphysema, which is air, as you can see in this case, which was post-traumatic. Just another example that I find very interesting, because in the chest X-ray, we detect calcified lymph nodes, a calcified lung nodule, and we identified the primary tumor in the humerus just in the margin of the image. Not all cases will be as obvious as this one, but it is a reminder of how crucial it is to evaluate all the structures in the radiograph. Another potential use for chest radiography is to monitor devices or control after thoracic procedures. This is a very common indication to see the location of devices, mainly central venous catheters, but also endotracheal tubes or implantable heart devices. Here we have an implantofix catheter for chemotherapy, which has a subcutaneous entry port, follows through the right subclavian vein, and the internal extremity is well positioned between the superior vena cava and the right atrium. Sometimes there is bad position of these devices. In this case, it is too much deep into the right atrium, and another case with the extremities of a double lumen catheter angled up. And finally, some other indications include compliance with government regulations, for example, in people who have contact with patients with active tuberculosis. One thing they do not recommend is to perform preoperative radiographs by routine and only when there are symptoms or possible pathology that may influence the anesthesia or the surgery itself. Now, we move a little bit down to abdominal radiography. Following the same scheme, we start with the how. There are also many variations for projections. The X-ray beam can be horizontal, parallel to the floor, to see free air or air fluid levels. The patient can be standing or sitting, and if he cannot stand, we can do a lateral instead, lateral decubitus. In the other projections, the X-ray beam will be vertical, and the patient can be supine, prone, or lateral. The prone position allows us to see if there is air in the rectum, because the air will rise, and in this position, the rectum is the highest part of the bowel. And why do we want to know if there is air in the rectum? It's basically to see if we have a complete bowel occlusion in which the air won't reach the rectum or not. The left lateral position is an alternative to those who cannot put themselves in the prone position, because in this position the rectum is also higher. In terms of adequate technique, an abdominal radiograph should include the area between the diaphragm and the inferior pubic rami. It should include the lateral abdominal muscles. There mustn't be rotation, so the osseous structure should be symmetric, and the exposure should be adjusted to each system and to the size of the patient. And what is normal in an abdominal radiograph? It is important to recognize the normal pattern of gas in the bowel. We almost always see some air in the stomach, rectum, and sigmoid colon. Only a small amount in the small bowel, 2 to 3 loops, and in the rest of the colon, it is variable. Another important point is that when we have fluid and gas, they form air fluid levels. This could be normal findings in the stomach and in the small bowel, but in the colon, the feces are no longer liquid, so we shouldn't have those levels. When they are present in the colon or in many small bowel loops, it is signs of stasis due to bowel occlusion. We can also identify organs which have soft tissue density, the liver in the right upper quadrant, the spleen in the left, and the kidneys at the level of the last thoracic vertebra to the third lumbar vertebra. We can realize when those are enlarged because they shift the air-filled bowel loops. And once again, never forget the bones and the soft tissues. The American College of Radiology also provides recommendations for when to order abdominal radiographs. The most common indications relate to abdominal distension, to search for bowel obstruction and its complications. Bowel obstruction will present with air distension of the loops, we can differentiate the small bowel from the colon based on their appearance and position in the abdomen. The small bowel loops are more central, as we can see in this case, which are distended and have air fluid levels. The colon will be more peripheral. The obstruction can be mechanic, and the most common cause for this in the colon is a neoplasm, and in the small bowel, the main cause is a fibrotic adhesion that formed after abdominal surgeries. On the other hand, we can have a functional ileus in which the bowel stops contracting due to electrolytic imbalances or inflammation, for example. When it is only localized to a single loop, it may serve as a sentinel for inflammation in that spot, for example, near the pancreas or the gallbladder. Another cause for obstruction is a volvulus, in this case of the sigmoid colon, that twists, and as it distends, it may originate a typical image that resembles a coffee bean in the radiograph. When there is air outside the bowel lumen, it can be free in the peritoneal space, or it can be in the retroperitoneum, in the intestinal wall, in the venous system, or in the biliary system. There are many causes, and we always want to exclude the worst ones, which are visceral perforation, for example, by an ulcer, and intestinal ischemia. To do that, it is extremely important to correlate with the patient's presentation. When the patient is standing, the air will rise, and it may originate these sickle-shaped air collections under the diaphragm. When the patient is lying down, the air spreads in the anterior part of the abdomen, and it can make the falciform ligament visible, which goes from the liver to the umbilicus, and this has been compared to an abdominal foot, an American football ball with the falciform ligament in the middle. Other indications include localizing ingested or retained surgical foreign bodies or video endoscopy capsules. It allows the depiction of intra-abdominal calculi, for example, in the urinary tract or in the pancreatic ducts. And besides calculus, as you can see in the gallbladder lumen in this example, many other calcifications can be detected in the radiograph, for example, in cysts, in the gallbladder wall, in the bladder, in aneurysms, veins. Here are some examples of pelvic veins, which is a very common finding, uterine leiomyomas, and prostate. In the abdomen, it may also be necessary to localize medical devices, such as gastrointestinal tubes or stents, or in this case, an intrauterine device. And some other indications are listed here: blunt abdominal trauma, which is mainly to detect free air or fluid. In children, they also mention palpable masses, necrotizing enterocolitis in premature newborns, and congenital gastrointestinal anomalies. One final image, just to show you how an enlarged organ will appear. In this case, the spleen, deviating the bowel with gas inferiorly. Soft tissue masses will also present with mass effect, occupying space and deviating the bowel. Now, let's change gears to fluoroscopy studies. This radiology technique allows for real-time visualization. Basically, we have a unit that can move the X-ray tube, the detector, and the table where the patient is. We can see the course of barium or water-soluble contrast along the digestive tube, for example. We can take spot films or record video clips. And obviously, as we are doing several radiographs in a row, the radiation dose will be much higher, and it should take the shortest time possible. I will briefly discuss some main indications of this kind of studies, excluding the fluoroscopy interventions that will be discussed in a different session. We can evaluate the swallow disorders and aspiration, for example, in patients who suffered a stroke. This is a swallow study in which the patient we tell the patient to put some contrast in the mouth and drink, and then we see the flow of contrast, in this case, normal descending to the esophagus. Here, we have a patient with difficulty swallowing, the contrast and aspiration to the airway. Esophageal motility disorders are well evaluated by fluoroscopy as they are dynamic processes. For example, achalasia is a disease in which the esophagus does not contract, and the inferior esophageal sphincter is hypertonic, which gives this big appearance, as you can see here, and the contrast is very difficult to pass. It won't pass to the stomach easily. Another example is the diffuse esophageal spasm, which originates this corkscrew appearance, and due to abnormal contractions, and the contrast even rises instead of descending. We can also evaluate gastric bands. In this case, it is too tight and the contrast barely passes through the band very slowly with upstream stasis. When we find this, we can deflate the band so it can pass more easily. Some other examples are hernias, reflux. All of these are much better evaluated with a dynamic technique, as you may imagine. Masses and ulcers are also well depicted. We may inject the contrast in biliary drains or fistulas and evaluate its course. In echoangiography, we inject the contrast in the biliary drain. Normally, the contrast should fill the gallbladder and the bile ducts down to the duodenum. We see if the ducts are dilated and if there is any obstruction. In this example, the drain is in the gallbladder, which is filled with calculi, and we have an obstruction that doesn't let the contrast leave the gallbladder. In a difficography, the contrast is administered in the rectum of the patient. The patient sits in a potty and simulates a defecation, expelling the rectal contrast, as you can see here. And we evaluate all the dynamic process. We see if there are prolapses or other anatomic or functional changes. In the postoperative setting, it can detect leaks and evaluate the integrity and patency of surgical anastomosis, for example, when the surgeon wants to close a stoma. It is an excellent technique to detect fistulas between organs, in this case, between the anal canal, where we administered the contrast, and the vagina, which appears opacified. This particular case was caused by injury during labor. We also have genitourinary procedures, a cystourethropy, where we administrate the contrasts through the urethra up to the bladder, and hysterosalpingography or hysterosalpingograms that allow to see the uterus and the fallopian tubes in female patients, to see, for example, if the tubes are patent, usually in patients with infertility. The last anatomical section that I will briefly mention is the musculoskeletal radiography. The main indications in this area are traumatic fractures and dislocations. Here are some examples of bone fractures in the fibula, in the femoral neck, and in the tibia. It is also helpful for evaluating some bone tumors. This could be lytic, there is radiolucent, as in this example of a humerus chondrosarcoma, or they can be sclerotic and dense. For example, in this case, we have a chondroid mineralized matrix in a femur enchondroma. We may find soft tissue calcifications and calcified masses. This is just an example of calcification of the arterial walls in an knee radiograph. We can evaluate articular pathology, either inflammatory or degenerative. Here is a nice example of degenerative changes in the cervical spine with bone osteophytes. Another example of severe osteoarthritis in the right hip joint with total loss of the joint space, subchondral bone sclerosis, and also osteophytes. Some other indications are osteomyelitis, acquired or congenital deformities, and evaluation of fixation material and prosthetic devices. We may follow the consolidation of fractures and check for adequate position of the fixation material in the tibia in this case. And we can evaluate joint replacements, in this case the hip joint, to check for adequate position or complications. Now, some final words about artificial intelligence. As last year I noticed this was of great interest for the audience in this course. As you are all aware, there are many different ways of training AI algorithms, and regardless of which one is used, a constant requirement is the need for a substantial amount of images to feed the algorithms, especially for unsupervised learning. Radiography is an ideal target as it produces an incredible amount of imaging data, and therefore it is an area where artificial intelligence is being increasingly implemented to address challenges such as validation and management of workflows. I will just mention some few practical examples. The ability of AI to detect lung nodules in chest radiographs was probably the first target, and it's well established nowadays. Other available functions include the detection of pneumothorax and pleural effusion, tuberculosis screening, and more general algorithms for detecting multiple pathologies. Also, during the COVID-19 pandemic, many investigation was done to cope with the large amount of chest X-rays that were being ordered. One example was the Radiology, a deep learning model that interprets chest X-rays quickly and prioritize the ones that are abnormal for early review by the radiologist. It was very successful, allowing for a 22% reduction in turnaround times, which is the amount of time it takes to complete a process. These tools not only allowed the improvement of the radiologist's productivity, but also optimized the clinical workflow by prioritizing sick patients who would require quicker assistance, which is especially relevant in the setting of an infectious disease. Besides chest radiography, pattern recognition has also allowed models to identify the design of failed hip replacement implants preoperatively, which could decrease the overall time and cost of revision procedures by identifying the right components to replace. Another example is models providing real-time automatic prediction of response to chemoembolization of hepatocellular carcinomas based on angiography videos. But like I said, these are a few examples of the many existent and under investigation possibilities for AI in conventional radiology. In summary, I hope that I transmitted that conventional radiology has many advantages for being widely available, fast and mobile. It is a good first-line exam, but it has low soft tissue resolution, and plus it uses radiation, so it should be used wisely. In all its applications, an adequate technique is key, and there should always be a clinical correlation. We must know the possible projections available and the normal anatomy. I tried to list the main indications and pathologies and pathological findings in chests, abdominal and musculoskeletal radiographs, and also in fluoroscopy. The final note was about the hot topic of AI, which has certainly a well-established and useful role in radiography and is being more and more implemented to address challenges such as the management of the workflows. These are my references, and I thank you very much for your attention. I will stop sharing now.
Thank you, Dr. Paula. It was a very nice presentation, a very complete one. There is a question which is in the Q&A. I can read it for you, and also you can check also
I can
which
see now.
Yes, which projection is good for chest radiography.
Yeah, so we have several projections. Like I said, those are based on what we can do and what we want to evaluate better. Since the heart is a structure that shouldn't be magnified to evaluate the rest of the radiograph, the one that we use more often is the posterior anterior. And if we need to localize or something, or see those spaces or the posterior costophrenic recesses, then we complement with the left lateral projection. Those are the most. When it is not possible, we have several alternatives.
Okay, thank you so much. I have one question, because you were it was very kind to mention artificial intelligence, and it was a subject that was mentioned in the course in the last year. For several attendees mentioned that they missed something about artificial intelligence, and it was very good that you mentioned yourself. But I have a question regarding that aspect. That is that some of us that work in artificial intelligence, we have a huge problem, that is to get images, and there is no very good images available in the internet, and there is no good data set banks. And are you aware of any actions that are being thought in the hospital to allow that your images in the hospital become available for research?
Yeah, I'm not aware of which regulations are in order to solve that, but I'm sure that the hospitals will have only advantages to collaborate with that. And in fact, if we talk about chest X-rays, for example, there are many done every day, so it shouldn't be difficult to get numbers. But I don't know by law what
What are the
what is
restrictions?
needed to have access to those images. But
Yes, we had an experience during the COVID to get data, and
But I think that if you have doctors involved,
yes,
then
of course.
it is easy to have access to those images. Because when we have works on our own, we get to use those images. So
Okay. thank you so much. Thank you again for your nice presentation.
Thank you for the invitation.
Okay. Now I let the organization. I think we are going to make a break now.
So, good afternoon, everyone. Can you listen to me? Okay, I hope yes. Let's start with the second part of today's session of the advanced course in biomedical imaging. We will have now Dra. Manuela Gonçalo, who is radiologist at the Unidade de Saúde Local de Coimbra. Her main interests include breast radiology and breast intervention, and also ultrasound. Thank you, Dra. Manuela, for your availability in being here with us today to talk about clinical applications of mammography. You can start sharing your presentation and start your lecture whenever you want. Thank you.
Thank you for the invitation to participate in this course. I'll speak about the mammography and its clinical applications. So I'm a radiologist working in the Department of Radiology in the University Hospital of Coimbra. And speaking about the breast, the main techniques we have to study the breast is mammography, which is considered the example. We have ultrasound, which is the next most important exam, sometimes the first line exam to study the breast. MRI is also a very important technique. So is intervention procedures that are being more important every day. I'll start with mammography, which is
Dra. Manuela, I'm sorry for interrupting, but I'm not sure if you think we are seeing your presentation, but not yet.
Sorry, I was not.
Take your time. We can see it now. Perfect. Thank you.
Sorry.
Okay.
There was only this slide showing the techniques we have to study the breast. Now about this not. Okay, let's go on. So mammography uses low dose X-ray. This is the kind of equipment we use for mammography. We have here the X-ray tube, and the breast is applied here close to the detector, and there's a paddle here that makes compression, keeping the breast here so that it can't move during the exposure, and making it smaller to use less dose, and getting all the structures to the detector so that there's less blurring of the image. After, what are the views that we usually do? There are two main views in the standard mammogram. One is the CT view, where the breast is compressed this way from the head to the foot. And the other, we use usually the MLL, medial lateral view. Why? Because we have to know that the breast parenchyma does not distribute equally throughout the breast. 70% of the breast tissue is located in the upper outer quadrant and maxillary tail and in the center of the breast. So we have to search more lesions in this area. That's why we use this lateral, medial-lateral oblique view to that it's this kind of view where we see most of this area instead of these areas where pathology is much less common. We only use the lateral when we need to know the correct location of a lesion, if it is inferior or in the upper quadrant. Otherwise, we we prefer this view. After the acquisition of the image, it goes directly to the diagnostic workstation, and we have to use panels of high resolution because we are looking for very tiny lesions like calcifications. So we have to have very high resolution panels. This is another workstation to show that in the workstation we have lots of tools that we can use to improve the visualization of the lesions. And here we can see that we can magnify an area of the breast. We can increase contrast to enhance visualization, in this case of tiny calcifications. We can have an inverted image that some people prefer to see these details. So there's lots of tools we can use, and there's also artificial intelligence that is becoming more popular in the use of radiology in general and in mammography in particular. We have systems like CAT that show us some with markers that show lesions that CAT finds a particular suspicious. In this case, calcifications are marked with a square, and other types of lesions with round spots. And we have to show this. This was a case of multicentric carcinoma. But if you look, there's another lesion here, more in the periphery of the breast, that is not marked by the CAT. So this is for you to be aware that AI is very important, but it does not always replace the eye of the radiologist. We have to look everywhere with particular attention to places that are marked, but we have to look toward the mammogram. There's another system that shows lesions or images that AI considers of some concern. And in this case, it shows what is the probability of being malignant. In this case, the computer size, it's about 20%. In this case, it's about 40%. Probability of malignancy. But mammography is a great exam to study the breast, but it has lots of problems that I will show you. The dense breast is one of the main problems of mammography. Dense breast a very dense breast appears in about 10% of women, mainly young women and pregnant women, which are also groups that are more vulnerable to the effects of ultrasound. So X-ray exams should be avoided in these groups, and ultrasound should be the exam of choice. The overlap of structures, because as you saw in the images, all the planes are imaged together, and so there are overlap of structures. Besides, it does not allow tissue characterization. We can't define if we see a lesion, if it's solid or liquid, and it is extremely important because it has different approaches. And breast cancer can have very different aspects on mammogram, and sometimes it's very difficult to differentiate benign from the malignant lesions. Breast deformities after surgery may also difficult the interpretation, as I will show you some examples. Breast prosthesis is the same problem. So lesions that are very in the periphery of the breast and cannot sometimes be included in the standard exam and cannot be shown in the standard exam. How can we solve these problems? With additional views, the use of tomosynthesis, contrast-enhanced mammography, AI, as I showed you some examples, and with additional exams, mainly with ultrasound, sometimes with MRI. So starting with breast density, we can have densities of the breast that are very different. The American College of Radiology classifies the breasts according to the percentage of breast cancer in 4 categories. In the first category, we can see a breast that is entirely breast. This is where the sensitivity of mammography is greater. The sensitivity decreases as the density of the breast increases. These are extremely dense breasts where the sensitivity of mammography is lower, and besides, there's an increased risk of breast cancer in these cases. I will show you 2 examples. This case of fatty breast, where we can see a very small cancer of about 4 millimeters. Here's the ultrasound aspect of round lesions with hyperechoic halo. In this case, the sensitivity of mammography is nearly 100%. This was a woman with a extremely dense breast. She had a palpable lump in the lower quadrant. We can't see nothing in the standard view. We had an additional view focused on the inferior part of the breast where she feels the lump. Here we can see some difference, and in ultrasound, there's no doubt there's a cancer, nearly 2 centimeter lesion. So we can see that lesion sometimes even larger and can be missed in these extremely dense breasts. Different aspect on ultrasound. Concerning the overlapping of structures, as we see, the mammogram is done this way, so every structure is in the same, crossed by the same beam will be in the same image. So what can we do? Additional views. One of them is magnification. In the case of magnification, this we do to study small details, mainly calcification. We still use this view a lot. In this case, we have to use a small focus to increase resolution, and the detector is apart from the breast, so that the image is increased. And as we use a small focus, the definition will be better. Besides, scattered radiation is reduced so that the definition of the image will also be better. And we see that calcification that cannot be clearly seen in the mammogram become very apparent here in this view. There are also other views like spot compression that can also be useful to show that a small image can in fact be a lesion, or if that's only parenchyma. And other views like rolled views to see images in different way, tangential views to see lesions that are more superficial. When we feel something, to be sure that what we feel at the clinical exam is in fact the image we are seeing in the mammogram. We can do the exam with a metallic marker, and we can do additional views for a lesion that more in the periphery of the breast. So we can do many additional views according to the special needs from the clinical examination or from the standard mammogram. Tomosynthesis is a technique that is nowadays available in most new equipment of mammography. It consists of a small movement of the X-ray tube that will be able to get different slices of the breast compressed, so that instead of having one image, we can have about 50 images, or more or less, depending on the size of the breast compressed. And it takes, of course, longer time to read because we have lots of images instead of only one. But with this technique, we'll have less additional views because it responds to most of our doubts. And with the tomosynthesis, the computer can make a sum of all the images and make a synthesized mammogram, which is a mammogram that looks like very similar to the digital mammogram that we are used to, and without an additional exposition. So the dose of the tomosynthesis nowadays is similar to the dose of the digital mammography. Some examples to see of the use of tomosynthesis. Here in this case, there's a small density, difficult to evaluate. And here in the plane, in the slice that comes through this area, we can see there is a small nodule density with oval shape and regular contour. And here I think it's almost impossible to see anything. And in the slice, passing through this nodule, we can see there's a small nodule, very low density and a well-defined contour. This was a small cyst. But the main use is to see distortions where it's really useful. We see here it's difficult to know if this is really a lesion. There's only an area of fibroglandular tissue. And in tomosynthesis, there's no doubt this is a lesion, a speculated mass, a distortion, and in fact, it was a small cancer. Here we also have a small asymmetry, difficult to know what what it was in fact. And we end this where we have the slice in the correct area. There's no doubt it's a speculated mass. It was a small cancer also. Contrast enhanced mammography is gaining more and more importance in the last years. It's based on the concept that malignant lesions enhance with contrast and they become visible, particularly in dense breasts, or to evaluate the real extension of lesions. In this case of a dense breast, with contrast, we see that this mass that is difficult to evaluate here, with contrast, it becomes very visible, very well visible. This was a case of microcalcifications. The patient was asymptomatic, and there were here some calcifications in the two views. When we do the contrast enhancement, nothing goes wrong with right breast, whereas in this breast of calcifications, we receive a large area of enhancement, showing that the cancer was in fact larger than it seems in the mammogram. Another example of a pleomorphic carcinoma, we see in the mammogram a huge mass that protrudes in the breast. And when we do the contrast enhanced mammography, it only enhances in the periphery with irregular enhancement. This is due because to this carcinoma had a very large cystic component that does not enhance in the contrast enhanced mammography. And besides it, there's another focus of enhancement in the other breast. If you look at the MRI of the same patient, the image look almost similar. So this SEM is used with as an alternative to breast MRI. It's much less expensive, more available, quicker, and more acceptable for the patient. Although there's some information, extra information that we cannot put in magnetic resonance imaging, but SEM can solve some of the problems. And as I said, mammography does not allow us to know if a lesion we see is solid or liquid, and this is very important because it has different approaches. A cystic like this has no problem. If this lesion is caused by a solid mass, we have to control it, or even do a biopsy if there's any kind of suspicion. So we have to use additional exams to be sure of what in fact we are seeing. And we also see that mammography can have in mammography, cancer and benign lesions sometimes look very similar. How can they present in mammography? There are different morphologies. Usually lesions are classified in these 5 groups as masses, speculated lesions, calcification, distortions, or asymmetries. These are all masses, all benign masses. In general, masses that contain fat are always benign, and we saw this is entirely fat. It was a lymphoma. This was an hamartoma with breast and fat and soft tissue distributed in a different way. And this is intramammary lymph node, which is also typical with this fatty hilum. And this is another situation that is very common in mammography, which is fat necrosis. The breast has great amounts of fat. So every time it suffers from trauma, it reacts with fat necrosis. These oil are extremely frequent after trauma. Sometimes they calcify. This kind of calcification poses no problem. Sometimes these calcifications are not so close and granular as in this case. Sometimes they're tiny and they pose some difficulties in differentiating from malignant calcifications. But in this case, they're all typically benign lesions that don't need any additional exam to know that are benign. This is also a typical benign lesion, a fibroadenoma with typical popcorn-like calcifications. And this is the same image as I showed previously. It's usually benign, a well-defined, small, low density with very regular contours, distinct, and so this kind of lesion is usually benign. Here we have another well-defined lesion, but it's round. It's very dense because it has blood. In this case, it was a papillary carcinoma. It has a round shape. This is an indistinct border, low density, but the indistinct border and round morphology. It was an invasive ductal carcinoma. So this is the typical appearance of malignant diseases as indistinguished borders, high density, and round morphology. The probability of malignancy increases. And another important point that we have to consider is the evolution of breast masses. Breast small masses are very common in the breast. We can do a biopsy in all of them. So when they look like benign, as in this case, that it has low density, oval shape, and regular contour in the area that we can see, we propose a follow-up of 6 months, and we consider that after 2 years stability, it is a benign node. In this case, in the follow-up, we can see that it enlarges, it becomes round, and with indistinct borders. So it's certainly a benign lesion, and it is most important in postmenopausal women where masses are not supposed to increase. Concerning speculated masses, they are malignant in more than 90%. This is how they show in mammography, very dense, and particularly in magnification views, we can see these speculated contours. In ultrasound, they look like this lesion, taller than wide, with irregular borders, sometimes with hyperechoic halo, and because of the stromal reaction, they sometimes have a very attenuating posterior, not allowing the visualization of the extreme of the lesion. Calcifications. These kind of calcifications are all benign. Calcifications, vascular calcification, popcorn calcifications, or the fibroadenoma completely calcified, as in this case. These are calcifications of fat necrosis and skin calcification in the periphery of the cysts, and plasma cell mastitis. All of these are typically benign. All these are typically malignant. These are vermicular calcifications with this type of calcification, very resembling the ramifications of the ducts, and these very grouped in very small areas of different shapes. These are associated with nearly 100% of malignancy. These also more than 90% of probability of malignancy. But most of the calcifications we see every day are not so typical of these. They have intermediate aspects, and we have to pay attention how they arrange and how is the morphology of them, and they are the main cause of interpretation error by the radiologist. It's all important to refer that calcifications are the main presentation of intraductal carcinoma. Architectural distortions do not usually have these so exuberant appearances in this case. This was caused by a surgery, by fibrosis after surgery, that we can confirm by observing the patient. Usually they are very subtle and difficult to find in mammography. They almost always need to be proven by biopsy because they may themselves be cancer or be high-risk lesions. As they are usually difficult to find, they are the main cause of perception failure by the radiologist. This is a case of an extremely dense breast. It's difficult to find, but we can look here some distortion, as in this case. In this woman, we have some additional views, magnified views, and we see with spot compression, and we see the distortion becomes much more visible. This was a case of cancer. Another case of a subtle distortion here and here. With an additional view, it becomes more visible. And in the radiology of the surgical specimen, there's no doubt that a speculated mass marked here by a hook wire. Concerning asymmetries of the breast are extremely common. They don't usually are so important as in this case, but it's very common to have different sizes, different densities arranged in different ways. And these are global asymmetries. They can be benign or malignant. Focal asymmetries are even more common than global asymmetries. I think everyone can see here there's a focal asymmetry in the axillary tail of the left breast. And if we have previous exams, we can see that is exactly the same as it was before. So certainly is fibroglandular tissue with no problem. This is another case of asymmetry that you can see this area is more dense than in the contralateral breast. In this case, with a spot view, we do a compression focus in this area. If it's parenchyma, it will become spread in this area. If it's a real lesion, as this was the case, it keeps it looks like a mass, and it was in fact a cancer. And these are the kind of deformities that we can find after breast surgery that surely will difficult the detection of small lesions in these areas. This was the case of a prosthesis that was removed, and surely a lesion in this area will be missed. Another problem is the presence of breast prostheses. They are used more and more common. And as you see here, if you do the breast compression with the prosthesis in the place, the breast tissue will not be visible because the prosthesis will be superimposed on the glandular tissue, and besides, it will increase the size of the breast compressed. So this will not be so compressed as it should, and the definition of this area will be very low. So we usually do this technique, and we only radiograph this anterior part of the breast, and we pull the prosthesis to the chest wall, so that this area will be much more visible, as you see, as in the other image. And we can't forget that men also have breasts. The main causes of breast enlargement is the increased by only fat or some gynecomastia, where we see some density in the area of the breast, but men can also suffer from breast cancer, and the aspects of breast cancer are similar to what we can find in women. The axilla the lower part of the axilla can be seen on the mammography, but this is not an exam to study the axilla. In this case, we have normal lymph nodes. These are adenopathy in the large breast cancer that affects almost all the breast. The main exam to study the axilla is the ultrasound, and we can confirm that a lymph node is positive by fine needle aspiration cytology or by biopsy. And we can't forget that the axilla is the most important prognostic factor in the case of breast cancer. We conclude the mammography report according to the Barhat's classification as inconclusive, which is a classification that we should always avoid. Every exam should have an appropriate classification. We conclude with an A when it's a normal exam. We classify as 2 benign findings, 3 probably benign with a chance of malignancy lower than 3%, and 4 suspicion lesions with different degrees of suspicion, and 5 it's almost certainly a carcinoma, and 6 when we are looking to a patient who has already proven breast cancer. So, what are the clinical applications of mammography? Breast cancer screening, the diagnosis when we are dealing with patients with symptoms, in the follow-up after the treatment, after surgery, looking for recurrence or studying the contralateral breast, to study the response of chemotherapy, and here the main exams are the SEM, contrast-enhanced mammography, or the magnetic resonance, and not the mammography alone. And also it's very important to guide interventional procedures. Breast cancer screening is one very important item because breast cancer now affects about 1 in every 9 women, so it's a very incidental cancer. In Portugal, the breast cancer screening is conducted by the Liga Portuguesa contra o Cancro in most of the regions. The women are called for mammography every 2 years. It's should be only done in healthy women because, as I told previously, mammography has some problems, and when a woman feels anything strange in the breast, she should do an exam dedicated to the mammography, sometimes with other exams, and not a screening mammography where she won't have a clinical examination or other exams, and the cancer can be missed. It's directed to women between 50 and 69 years. Some time ago, women started being called at 45 years, and it will become again, this group will soon be integrated in the breast screening program again. Breast cancer screening programs allow a reduction in mortality by breast cancer in about 20 to 40%, which is a very important number. And besides detecting very smaller tumors, it allows less aggressive and more efficient treatment. How does it work? We do double reading. Two readers read and classify the images without knowing the results of the other. We classify like this. If it from 1 to 5, we classify the lesions according to morphology and to the sites where the lesions are located in the breast. Here was a carcinoma that is located, it's a speculated mass in the upper outer quadrant, and we classify as 5, for example. And how does it work? After double reading, if both readers consider it's negative, it's considered a negative exam and the patient goes back to screening 2 years later. If both consider positive, it's considered a positive exam. The patient goes to a medical appointment. If it's positive, she goes to a hospital to be treated. And if there's a difference between readers, there's a final reading for by a third reader. And if he considers negative, the woman goes back to screening. If considered positive, the patient also goes to a medical appointment. Most of the cases going to these appointments are considered negative and go back to screening. And there's also a possibility of considering a doubtful exam, not considered positive to additional biopsies, but there's some doubt, and we can recall the patient for 6 months or 12 months. And after this, she has to be considered as negative or positive. So, mammography is the only exam with proven efficacy in population-based breast screening programs, but it has limits. One of the problems are the false negatives. They are more common in dense breasts, and in some cases, as we see, lesions in the periphery of the breast, sometimes missed in the standard mammogram. And they're also false positives. They're more common in the first round in young women, in dense breasts, and they cause anxiety. We have to do additional exams as they are considered positive. Ultrasound, MRI, even biopsies that can classify them as positive, and they will certainly increase costs. And another problem is the overdiagnosis that will cause overtreatment. What is overdiagnosis? It's breast cancer that's detected at screening that would not cause death. They're usually cancers that grow very slowly, and they suppose that women are treated without need, but I think no one can be sure that a certain breast cancer will not at certain time become aggressive. So for me, this is a false problem. But besides screening, mammography is also very important in diagnosis. And when a woman has symptoms, they're mainly a lump or skin or nipple changes. And the mammography is very important, but is usually complemented by other techniques, mainly ultrasound. There are limits. Breast cancer, as I told you, have many different presentations, from masses to calcifications, distortions, and sometimes lesions. Benign lesions look like malignant, and they're difficult to distinguish. So biopsy is usually needed. Every time there's a suspicion, we have to do a biopsy. So when we have a lesion, we need to have a precise diagnosis before surgery or before chemotherapy to plan the best treatment. And so we do more and more often biopsy guided by mammography or ultrasound, so that diagnostic surgery should be reduced as much as possible. And with the development of screening programs, most breast cancers are infraclinic, so the radiologist is essential for adequate treatment to guide surgery, because if the lesion is not palpable, the surgeon does not know where the lesion is, and we have to guide the surgery. So intervention techniques are extremely important in the diagnosis to guide surgery, and more often even in the treatment, mainly a small lesion, but it's becoming even in use in the treatment of some cases of cancer. The techniques of guidance are mainly ultrasound is the technique of choice. It's much more comfortable for the patients, and we can feel during the procedure, we can know exactly where we are picking the sample. When the lesion is not visible on ultrasound, we have to guide by digital mammography, or if it's not visible in one of these techniques, we have to guide by magnetic resonance imaging. So what are the techniques of intervention? We have galactography or ductography, and procedures guided by stereotaxis or tomosynthesis. When do we perform a ductography? When in cases of nipple discharge, usually only in discharge by a single duct, we have to categorize the duct that is with the discharge, in this case, a bloody discharge. And we can have images like this, in this case, a cancer. We can see the contrast in the duct, and we see here a stop caused by tumor. This patient also had calcification, and this is a typical image of a papilloma, that one of the causes that causes more often nipple discharge. It has a smooth contour, a stop here. The procedures guided by stereotaxis or tomosynthesis are performed mainly in cases of calcifications and architectural distortions that are not seen on ultrasound. When they are seen on ultrasound, even calcification, the procedures should be used with ultrasound guidance, because the areas where we see the calcification on ultrasound are the sites where more often there's invasive carcinoma, and we should direct the biopsy to those areas. In these procedures, the patient is laid down. We use this technique in the hospital. There are also some prone tables dedicated only to this type of procedures. And what kind of procedures we do? Biopsy. In the case of guided by stereotaxis or tomosynthesis, we use more vacuum-assisted biopsies, mainly with 7 or 10 gauge, because mainly we are dealing with calcifications, and the most correct, there's a more correct final diagnosis when we have larger samples. So that's why we should use vacuum-assisted in these cases. And we also use this kind of procedures to mark lesions. When do we mark them? Previous to surgery, as we are, there are infraclinic lesions, and the surgeon has to know where they are. We use mainly hook wire, because we mark the lesion usually in the same day as the patient is operated. Otherwise, we can use seeds. We also use very often seeds in our department. There are different kinds of seeds that we use, some ferromagnetic, others with radio frequency, and some with radar. And we also mark lesions after biopsy. Mainly when we use vacuum-assisted biopsies, sometimes we remove all the calcifications, all the lesion, and we have to let a marker to know where we have done the biopsy. Even sometimes we do radiology excision, guided excision of lesions. We also have to let a clip or a seed in the place of the biopsy or the excision to know where exactly the procedure was done. And before chemotherapy, we also have to mark the lesion because sometimes there's a complete response to chemotherapy, and if the place is not marked, we don't know where the tumor was, so that the site of the tumor can be later removed. We usually mark with a clip, sometimes with a seed, and this is the kind of the biopsy needle that we use for the vacuum. This is how the stereotaxis works. We have two different projections, and the computer automatically calculates the depth of the lesion when we choose in the monitor. Here we have a case of very tiny, a small focus of calcifications. Here this is in the zero projection, the two different projections of 15 degrees. When we choose this area in both projections, it automatically calculates the coordinates of the lesion. We see the guide of the wire is in the focus. So we open the wire, and here we see the wire when we do the mammography, the control before the patient goes to surgery. And the radiology of the specimen that we have to do every time to confirm that the lesion was removed, the wire and the calcifications. And even when we introduce the wire through ultrasound guidance, as in this very small cancer, 3 millimeters, we have to do the mammography to confirm that the wire is in fact in the lesion, and the radiology of the specimen, where we mark the site of the cancer for the pathologist. Another example of stereotaxic guidance in a case of microcalcification. In this case, it was a biopsy, and we have to radiograph the specimen to be sure that the samples were in the area of interest. And you see here the samples with lots of calcifications. When we use tomosynthesis to guide the biopsy, we do a series of tomosynthesis, and we choose the slides where the calcifications are more visible. It was this case. We chose this area, and here everything is okay. These are all in green, so we are in place to see perform the biopsy, the needle. We can do stereotactic views to be sure that we are in the correct place. And after we mark the area of the biopsy with a clip. Here are the specimens, we radiograph them, and as you see, there are lots of calcifications around here. So the biopsy was okay. This is another case guided by tomosynthesis, where there was a tumor marked with a clip. There was a complete response to chemotherapy. Now we only have the clip, and it shows the slides where the clip is well viewed. We have to introduce the wire, we have the guides that are just near the clip, so it's okay. We open the wire, and it's just close to the clip. Here, the radiography of the specimen with the clip and the wire. The procedure is almost alike. Here was a small cancer with the seed. The patient is going to be operated, not in the same day as the seed was placed. And here is the specimen, the surgical specimen that we radiograph always. It has the cancer and the seed inside the tumor, a very small tumor. This was a ferromagnetic seed. This is a radar with a different format, but it's similar. And how does in the case of the wire, the surgeon follows the wire. In the case of the seeds, they have counters in the surgical room, and some tell with a noise when the seed is getting near, and giving signals that it's getting more and more near. And in other cases, it shows the real distance to the seed. Another case is of clips. In this case, after chemotherapy, we have here a large tumor. We had two clips to show the extremes of the tumor. They were placed under ultrasound guidance, but we have to also to do an X-ray to confirm that the clip is well placed. Here we have another view. And to conclude, breast lesions are increasing in last years. In particular, breast cancer is increasing more and more often. Every day there are younger women with breast cancer, and screening permits detection of smaller lesions, allowing more conservative therapy, more conservative surgery, lower mortality by breast cancer. Radiology and intervention techniques have important role on more accurate diagnosis and staging, and allow better therapeutic planning. And extremely important to analyze images integrating with clinical examination, previous exams, and other imaging techniques. In the future, I think there will be technical improvement, mainly in contrast-enhanced mammography, in cross-sectional imaging, and curative intervention techniques will also develop. We are already doing vacuum, blaze, and cryoablation. AI is also improving. I think not better than radiology, as some papers are suggesting. It also has false negatives, but AI is already being used as a second reader in some breast screening programs. I think it's a very important help for the radiologist, but not replacing. Thank you very much, and that's all.
Thank you so much, Dra. Manuela, for this very nice presentation. For now, we don't have any questions in the Q&A or in the chat. We still have time for questions if anyone wants to raise one. I have one question related to radiation exposure. So being breast cancer screening a repeated procedure, I know that we already use low doses of radiation in these exams, but what you can say about the balancing of these radiation doses? Will we be able to decrease even more the radiation dose exposure, ensuring the image quality, or are we already in the lower levels that we can achieve to obtain good images?
I think those nowadays is very small, and I think that's not a real problem, because it's the quantity of lives that are gained using screening programs. It's much more important than the risk of gaining a breast cancer caused by radiation exposure by mammography. But screening is also very discussed nowadays, and they're even discussing how can we change to more personalized breast screening, increasing screening in patients of high risk in breast cancer, and decreasing screening in patients of low risk. But nowadays we keep on going with large base population screen, because large studies show that in fact it enables a reduction in nearly, some studies show a 40% reduction of breast cancer, mortality for breast cancer. So I think it's most important, very important, and it saves lives. The probability of getting the cancer because bioradiation exposure by mammography is very low nowadays.
So still the benefits still surpasses the risks. Okay, thank you so much, Dra. Manuela. We don't have any more questions, so we just want to thank you for your time and for being here with us, sharing your knowledge on this. Thank you. So we will continue with our program, and for now we will have Dr. Paulo Donato, who is the Director of the Medical Imaging Service at the Coimbra Hospital and University Center, and he is also Assistant Professor at the Faculty of Medicine at the University of Coimbra. He has played an important role in the continuous improvement of the quality of the services provided by the medical imaging service that he manages, from teaching to the implementation of new radiological techniques and interventional radiology, as well as clinical research. Professor Paulo, we thank you for accepting our invitation, and I'd like to give you the floor to talk us about interventional radiology.
Okay, thank you. Good afternoon to all. Thank you for the invitation to participate in this meeting. So we'll share my presentation. I don't know if you are already seeing my presentation.
Yes, not in presentation mode yet.
Okay, no, it's fine.
Yes,
So
perfect.
how long do I have to have the presentation?
You have 1 hour or less if you want to.
Okay.
We have time.
Because in English, I think I will have more. I have to have more time than in Portuguese. So
No problem.
okay. In this lecture, we will revise the main interventional radiology techniques, their indications, and the necessary conditions to do them. We will also alert to the advantage of these techniques, but also for the limitations of interventional radiology. Interventional radiology, as you know, is a set of image-oriented techniques for biopsy or targeted therapy. Most are minimal invasive alternatives to surgery. In this presentation, we will see a set of techniques of two main groups of interventional radiology. One is non-vascular intervention, and the other is vascular intervention. We will see some biopsies, drainage, CPTH. We will see lots of cases, and we'll discuss some indications and limitations of these techniques. Biopsies can be made by aspiration cytology, in which we use a small needle, and where you can only get some cells for exam. By cutting, we can sample, can get a small amount of tissue, and that is what we do for liver biopsy, lung biopsy, for breast nodules, and also for soft tissue masses. We can get a small part of tissue, bigger part than by cutting, using vacuum tissue biopsies, as you have probably seen in the last presentation. But we still have the surgical biopsies when we have inconclusive results, or where we have an inaccessible location by percutaneous access. In aspiration cytology, we have a small needle from 20 to 25 gauge. So with such small needle, we have a low risk of bleeding. When we do a cytology of thyroid or of lymph node, we don't have to have small analysis prior to the cytology because the bleeding risk is low. The disadvantage is that we only do the evaluation of a small amount of cells. By cutting needle, we can get a small part of tissue. Usually, we do the cutting needle with a 18 gauge needle, and we can get the small parts of the tissue that is in the lung or in the liver or in the soft tissue. We have a moderate risk of bleeding, so we need to have pre-procedure tests. You also have to suspend some antiplatelet medication that the patient has, or some anticoagulant indication that the patient is under. As you probably know, as the nodule is bigger, the risk of the malignancy increases. So for the lung nodule, the incidental lung nodule, we have indication to perform biopsy when there is a 8 millimeter nodule, or if there is a persistent partial solid nodule, or a pure grain glass nodule that persists in the sequential examination. There are minor complications and major complications for the lung biopsy. The pneumothorax is very frequent, but usually we don't need to have any intervention in the small pneumothorax. Pulmonary hemorrhage and transient hemoptysis is also expected after a lung nodule biopsy. We should avoid large pneumothorax, hemothorax as bleeding to the pleural cavity, gas embolism that can conduct to death. The tumor seeding of the tumor is also a risk, but I think it's not a very important risk in our biopsies. The pneumothorax is very frequent. 25% of patients who underwent pulmonary biopsy can have pneumothorax, but only 5% of them have a pneumothorax with the amount of gas that needs intervention. So the complications, the major complications after pulmonary biopsy is less than 6%. Other technique is the drainage, the percutaneous drainage, and there are two main techniques to do drainage, abscess drainage. One with a single step in which we have to have a 3-part coaxial drain with the needle, the metal shape, and the plastic drain. In this technique, we go in one step with the large cutting drain, and the risk of bleeding is increased. When you use a multiple step technique, you use a needle, a small needle with a shape, a support guide, and a drain. So the risk of puncture of a large vessel or the risk of puncture of the bowel is less when you use a small needle than this single step technique. But the single step technique is less time consuming and it's easier to do than the multiple steps technique. There are two main methods to guide our drainage. The echography has the advantage of being a dynamic study, the advantage of no radiation exposure, the advantage of less material and human needs to be needed. The disadvantages are related with the technique. Gas interposed, the obese patients, deep targeted are difficult to reach by echography. So the advantages of computed tomography are the disadvantage of the echography. And also, it is a less operator-dependent technique. The disadvantage is to use the radiation in the less capacity of visualization of our needle and the progression of the needle when you are doing the technique. The pulmonary abscess may have indication to percutaneous drainage. The pulmonary abscess are related with bacterial infections that causes pulmonary necrosis and lead to prolonged antibiotic treatment. The pulmonary abscess have a worse prognosis when they have more than 6 centimeters, and when they have such a large dimension, there is a probably failure of the treatment, the oral medication treatment. So we can complement the treatment by percutaneous drainage. Drainage is made after the skin disinfection. The root is the control of the pain is done by injection of lidocaine in the root with a small needle. And there are also complications such as pneumothorax, emphysema, bronchopleural fistula, and hemorrhage. In pleural empyemas, there is a collection in the pleural space. It's a condition with high morbidity and mortality, and the early drainage should be done and directly in the more roots with less structures between the skin and the collection. Liver abscess have in developed countries have bacterial etiology associated with comorbidity, such as intra-abdominal infection. Usually, we have to have a collection with 3 centimeters to have indication to drain to the abscess. We try to avoid the peritoneal space when the collection is retroperitoneal, such as this iliac abscess, and the root should be more accessible and more direct, avoiding the other organs such as the lung in this case. In this collection of the pancreatic tail, we didn't have roots that avoid the peritoneal space, so you have to assess the collection by a peritoneal root. When you do a drainage, you should monitor the patient for 4 hours. We recommend 2 hours in bed rest, and the drainage is quantified daily. When the drainage is completed, you should make imaging modality before removing the drain. The drain can be blocked, can be obstructed, or can be outside the collection. So in order to know if the collection is already treated, we have to image the patient. Another example of non-interventional, non-vascular interventional is transhepatic percutaneous cholangiography, CPTH. It's a technique under fluoroscopy for visualization and therapy of the biliary tract. It's a high-risk bleeding technique. We place a needle inside the biliary ducts, and that needle will support a guide wire, a sheath, and then we can access the strictures at the biliary duct, and we can, in unresectable neoplasms, we can place a metallic stent. It's a treatment of a patient that can improve the quality of life of a patient that has an unresectable neoplasm. A patient with pancreatic neoplasm usually has jaundice, have liver dysfunction that can be improved with the stent placement. One example of a cholangiocarcinoma of the bile duct treated by a stent, metallic stent. Was a patient with carcinomatosis, a patient with an unresectable neoplasm that was treated with a metallic stent. In resectable neoplasms, we can improve the liver function, decrease the jaundice with the external drainage before the surgery. In benign structures, we can do progressive dilatations or use biodegradable stents that does not have the problems of obstruction long-term obstruction that the metallic stents have. In this case, there was a stricture in the biliar anastomy. The jejunal access was made by a guide wire, and we could dilate the stricture with a balloon. We placed the drain between progressive dilatations, and we could treat these patients with the benign stricture in the left lower lobe with the progressive dilatations. The other techniques that are non-vascular are the ostomies, percutaneous ostomies. The gastrostomies is a technique where you can direct feeding the patient, and usually is indicated when there is an impossibility of the direct feeding for more than 4 weeks. It's a moderate risk of bleeding technique, and can be made also by endoscopy. So it's a technique that can be made by radioscopy, visualization, or endoscopy. The cholecystostomy is a technique that is made nearly any day, daily in our department, and where we can treat acute cholecystitis without when the patient doesn't have surgical conditions. Usually we put the drain with a foot that passes by the liver parenchyma, and the liver parenchyma serves as a clot for closing the roots when we remove the drainage. The nephrostomy is a high risk technique for bleeding, and is a kidney function salvage technique. There are a group of techniques that use ablation. Local ethanol injection conducts to a cell destruction with little accuracy, and nowadays is no longer used. You can do ablation by local heating, caused by thermoablation or microwave ablations, or by cryoablation, by local cooling. By cryoablations, you can see the ice ball visualization that estimates the tumor necrosis, and the ball visualization is seen in CT, where the microwave ablation is not seen. A technique of electroporation is a technique of destruction with electricity pulses, condition tumor destruction with maintenance of the surrounding tissues. is a technique more expensive than microwaves or cryoablation and less used. Even metastases and carcinoma, hepatocellular carcinoma, have indication for percutaneous ablation when have small dimensions up to 3 to maximum 4 centimeters. Renal cell carcinomas, small renal cell carcinomas, especially in patients who doesn't have surgical conditions, can be treated by ablation, namely by cryoablation. Patients with carcinoma, lung carcinoma or metastases can also be treated by thermal ablation. Painful metastases of the bone or the osteomas osteoid, that is a benign pathology with painful, very painful. The pain can be controlled by ablation of the nidus of the lesion. We have revised the categories of non-vascular intervention. Now we will see some cases of vascular interventions: arterial, venous, vascular interventions on oncology, and also in portal hypertension. First, we will have a brief history of angiography. In the 50s, Seldinger have revolutionized the vascular access with this method, with less hemorrhagic complications during the process and less complications such as pseudoaneurysms at the site of the puncture. Charles Dotter have made his first angioplasty in the 60s, balloon angioplasty of the femoral artery. Then in the 70s, there was the first treatment of a endovascular treatment of a gastrointestinal hemorrhage. Stenting was developed in the 80s, and nowadays, for do any of this technique, you have to have a fluoroscopy unit with a digital subtraction technique. We have to have a table that has a movement and also arm with the ampule and the field with a rotation capacity in the axial and the sagittal plane. We also have a room such like this that has a almost operating room condition with an adjacent washroom, monitoring equipment with gas ramps, ventilator. Some of these techniques are made under anesthesia. We also have to have an ultrasound machine available, manometry equipment, and direct lights like in the operating room. Some examples here in the patient with the right limb collocation, where we have performed aortic angiography, and we could see occlusion of the right iliac artery. This occlusion was treated by stenting. First, we have passed with a guide wire. Then we have put the stent, and finally we have reached caliber similar to the left iliac in the right occluded right iliac artery. In another patient with a right occluded iliac artery that have also a occlusion in the femoral artery, superficial femoral artery, treated with angioplasty, and then you have also placed the stent in the right iliac. You can use stenting in the carotids, in the large arteries like the aorta. This patient with a traumatic event, it was a car accident that conducted to a aortic dissection with lumen intima laceration here. The laceration was treated with a stent graft, and 1 year after there was a total resorption of the false lumen. When you use stent graft in the aorta, we have several risks, such as cerebral infarct and especially vertebral ischemia. When you have a symptomatic aneurysm, abdominal aneurysm, we have a condition to treat this patient. But if the patient is asymptomatic, the risk of rupture increases when the caliber of the aneurysm is over 5.5 centimeters. When you have a 5.5 centimeters aneurysm, the pressure into the whole of the aortic aneurysm is such high that the risk of the spontaneous rupture is more than the risk of treating the patient. So if you have a patient with a large aneurysm, we have also indication to treat them if the patient is asymptomatic. In mesenteric ischemia, we have a collateral circulation. So patients are usually asymptomatic when they have only stricture, stenosis of one of these artery. This patient had a long stenosis of the mesenteric, superior mesenteric artery, and also atherosclerotic plaque in the sleeve trunk, and have several times with abdominal angina, and the stenosis was treated also with stenting, focal stenting. In liver transplantation, we can do arterial, portal, venous angioplasty, also splenic embolization and biliary intervention. In this patient, there was a stenosis of the hepatic artery, and the stenosis was treated also with a stent in this patient. This large splenic artery was also embolized by coils in order to decrease the amount of flow of the portal vein after the transplant. One patient with a stenosis in the portal vein, anastomotic stenosis, we have reached the portal vein by percutaneous access and also by stenting. We have made angioplasty. This patient had also exuberant collateral circulation that was excluded by plugging with a two great plugs. In kidney transplant, we can also do stenting, arterial stenting, or you can embolize a non-functional kidney. After transplant, we can avoid a surgery if the kidney doesn't work and causes hematuria or hypertension. We can embolize the kidney with small particles and coiling and avoid and treat the hematuria or the hypertension that the kidney leads. The most frequent cause of secondary hypertension is renovascular hypertension and can be treated also by endovascular stenting. This is an angiosity of the stenosis of the left artery, renal artery. The angiography confirmed the stenosis, more than 90% stenosis. The calcified part of the plates and this soft tissue part of the plate seen in the CT, and the treatment by stenting also. There are many agents of embolization. Some are temporary, such as shell foam or the autologous blood clots, but the most used coils and small particles, such as polyvinyl alcohol particles, are permanent embolization particles. We have also liquid polymers and liquid sclerosants to do embolization of the vessels. Here we can see bleeding into the left part of the colon caused by a diverticulum, and the treatment made by coiling. It's a treatment made by from the 70s of the last century. Usually, the patient performs first a colonoscopy or endoscopy, and then the treatment is made by endovascular when the endoscopy treatment is not successful. In this patient, there was a pancreatitis, acute pancreatitis, that led to bleeding from the gastroduodenal artery, and The bleeding was controlled by coiling the gastroduodenal artery. Another patient with a plague in a bleeding from the gastroduodenal artery that had a recurrence of bleeding from the inferior pancreatic artery, treated by coiling, selective coiling. Another patient now with the right colon hemorrhage, treated by coiling in the right colon artery. Another one with bleeding from a diverticulum, a sigmoid diverticulum, that was treated by coiling. You can treat also by endovascular way massive hemoptysis. We speak about massive hemoptysis when there is a large amount of blood in the lower respiratory tract. When the patient is unstable, the first technique is bronchoscopy. When the endobronchial treatment fails, there is a place for bronchial artery embolization. In the stable patient, we should always perform a CT scan in order to plan the endovascular treatment. Not only to depict the anatomy that is variable in the bronchial arteries, but also to see the underlying cause. There can be the patient can have bronchial dilatations, can have tuberculosis, can have several causes of hemoptysis. Here you can see the selective right artery, right bronchial artery angiogram with vascular sterilization treated by coils and injection of small particles. The bronchial arterial embolization is very effective for the immediate control, but there are complications such as chest pain, and the worst complication, the one that we are most afraid, is medullary infection. We try to avoid this complication when doing the embolization more distally, but we are always afraid of causing medullary infection when we do bronchial artery embolization. There is a large amount of patients that have recurrence hemoptysis after arterial embolization, and the recurrence depends the underlying pathology. The inflammatory process of aspergilloma is the most frequent cause of recurrence. We can treat several places of bleeding. We can control this liver hematoma after a liver biopsy with spongostan, selective injection of spongostan. We can also treat this complication after a kidney biopsy using injection in a small catheter, a microcatheter, avoiding infection of the rest of the kidney, and control the bleeding only on the small artery that is bleeding with particles and also with coil. In large arteries, we can control the bleeding, such in this case, that was a tent of central venous catheter that was placed in the artery and the subclavian artery and leaded to a hemorrhage that was treated with a stent graft, avoiding the distal complications of ischemia of the upper limb. In the superior vena cava syndrome, that can be caused by tumor or by benign strictures, we can dilate the stricture, and the dilatation is made by stenting when the cause is neoplasm, and by balloon dilatation when the stricture is benign. This set of patients usually have dyspnea, cyanosis, and edema of the face, of the neck, the upper limbs, and after the treatment, the symptoms relieve immediately. In this patient which have central venous catheter that lead to a benign stricture. The treatment was made by balloon dilatation. In this one, that had a central neoplasm involving the mediastinum. The treatment was made using stenting. We can have also complications when we treat this kind of patients. When we use stent diameter more than 16 millimeters, the hemorrhage is a risk. When we use a stent smaller than 16 millimeters, we can have a risk of stent migration. So we have to select very well the dimension of the stent in order to avoid stent migration and avoid the hemorrhagic complications related with the dimension of the stent. In our hemodialysis, we have to have flow in the venous, in the peripheral venous, high flow in the peripheral venous that is achieved by a arteriovenous fistula made usually by surgery. These kind of vessels are prompt to stenosis that influences the flow in the puncture and the vein of the puncture for the dialysis, leading to large time of dialysis, the impossibility of do the hemodialysis. So we can delay the stenosis and achieve greater velocity in the vein. That is the access of dialysis. A condition that is very frequent is the varicocele, the enlargement of the spermatic vein that leads to a varicocele. Nowadays, the first treatment of this condition is embolization of this vessel, and this is usually achieved by placing coils in the spermatic vein. We can do embolization of several tumors, and hepatocarcinoma, and bone neoplasms, and renal neoplasms, and fibromyalgiomas, uterine fibromyalgiomas, and then malformations, vascular malformations, neoplasms. In hepatocellular carcinoma, the embolization can be made by lipiodol or by microspheres with therapeutic agents like doxorubicin, where we have the embolizing effect of the microspheres and the direct effect of the chemotherapy release. We can also have the treatment can treat endovascularly the hepatocarcinoma by radioactive spheres. Usually, this kind of treatments, such as TER, radioembolization, or chemoembolization, is indicated in an intermediate stage in order to achieve a therapeutic stage, curative therapeutic stage. Downgrading the hepatocarcinoma is a goal for chemotherapy, direct artery embolization. Here you can see the large hepatocellular carcinoma with this retention of the contrast. This is a neoplasm that is very vascularized, and after chemoembolization, we can see that the tumor is completely devascularized. There are tumors that get vascularization from arteries that pass nearby, such as this diaphragmatic artery that was near the tumor, and the CT for planning therapy is crucial for a good global treatment. We can combine therapies such as radiofrequency therapy. This was a small hepatocellular carcinoma that was treated by microwave ablation, but in the end of the treatment, there was a small amount of peripheral of the tumor that was vascularized, and the treatment was completed with chemoembolization of the tumor, with completed the treatment of the tumor. In a renal cell carcinoma, we can decrease the vascularity, control hematuria, or control spontaneous hemorrhage when the patient is surgically treated as a condition that leads to there's no condition to surgical treatment. Here you can see a small renal cell carcinoma that was embolized and excluded, supraselective embolized, and the rest of the kidney, vascularity of the rest of the kidney was preserved. This patient had several contraindications for surgical treatment, and the hematuria was controlled by the embolization. Angiomyolipoma can cause hemorrhage. This case was had a spontaneous hemorrhage. Iris of hemorrhage depicted in CT, caused by pseudoaneurysms in the tumor that were treated with coiling. This type of benign tumors have indication for preventive embolization when they are large because of the risk of spontaneous hemorrhage. To prevent spontaneous hemorrhage, we can embolize tumors that are more than 4 centimeters. We can embolize bone tumors, like in this case, that have a painful osteolytic metastasis of the right humerus from a left lung carcinoma, and the pain was relieved by embolization. In the portal hypertension, we can do tips, preventive tips to the risk of bleeding from the collateral varices. We can treat also refractory ascites by tips, and can sclerize the varicose vein that is bleeding by the tips access. This is an example that of a patient with a gastric balloon, where the control of the bleeding was made by an insufflated balloon in the gastric lumen, and by a transocular access, we have reached the portal vein. We have to use a needle to do a narrow route between the systemic venous liver vein to the right portal vein, in order to place a stent that decreases the portal hypertension, and also we can reach the left gastric varices and embolize them with coils. Last example of a technique, closure of a shunt in a pediatric patient between the portal system and the systemic system with a plug, and the 3D planning and evaluation made by CT. So we have multiple imaging techniques guided by imaging methods. Usually we have lower risk than a surgical procedure. We have a variable short and medium term efficacy, and usually we can recurse to a new therapeutic intervention after the first one. This was the presentation that I have prepared to present. I don't know if there are questions.
Thank you, Professor Paulo. We don't have questions for now. So, anyone have one question? No, it seems it was very, very clear. So thank you so much for your time and for this great overview on the interventional radiology. Thank you. So this way we will finish our session for today. I just want to remember that in the next week we will not have sessions of this course. We will be back on April 18 with the topics microscopy and ultrasonography. So thank you for joining us today, and see you in the next session, April 18. Thank you. Bye bye. Have a good weekend.